session of the MRI in bone and soft tissue sarcomas. I am Dr. Amit Sahu from Max Hospital, Sakir. I will be discussing the role of MRI in the assessment of the bone and soft tissue sarcoma in the diagnosis as well as in the post-treatment follow-up. So the teaching points in the session will be the history, which is a very important part in the clinical settings, where we need to diagnose the pathology in a coordination manner with the clinician and the pathologist. The radiograph is the primary screening modality. It should not be forgotten. It is indispensable. MRI is superior to the other imaging modalities in detecting bone marrow lesions. MRI is very helpful in local staging and surgical planning, and is also used in assessing the response to neoadjuvant therapy, restaging, and post-treatment follow-up. The MRI protocol is based on the T1 and the fluid-sensitive stir sequence and the T2 sequence. So T1 basically evaluates the bone marrow lesion characterization. The stir suppresses the fat, it enhances the fluid, that's why it is called as fluid-sensitive sequence, and it also enhances the edema. The T2 is used to lesion characterization and treatment assessment. The other optional sequences are the T2 fat suppressed, where the fat gets suppressed and the shows extent of the edema better. It is also helpful in case of the lipoma and hemangiomas. T1 fat suppressed image is used for pre and post contrast imaging for assessment of the lesion. Chemical shift imaging, like the pre and post contrast imaging, is used for the marrow infiltration metastasis in myeloma. Diffusion weighted imaging is also helpful. Spectroscopy has also got some role in assessment of the sarcomas, whether it is a bone or a soft tissue. And dynamic contrast enhanced MRI has a very important role, which I will be talking as we move forward in this discussion. In case of bone sarcomas, the MRI has a very specific role in accurate lesion detection to differentiate between benign and malignant lesion. Specific soft tissue component to be assessed. In case of fluid levels, such as in case of tall injected osteosarcoma versus that of bone cyst. There are some T2 dark lesions, such as in 63% of the giant cell tumor and 86% of the chondroblastomas. Similarly, in case of non-swelling fibromas. Patients with hematopoietic malignancies and pre-malignant gammopathies has a very well assessment of the MRI. Similarly, perilesion marrow edema needs to be differentiated from the disease. According to the AJCC staging of the bone tumors and the soft tissue sarcomas, stage 1 is less than 8 cm, stage 2 is more than 8 cm, stage 3 is we get skip lesions, and stage 4 is distant metastasis. We also need to see the physeal and epiphyseal involvement, whether the muscle involvement is there, which is better seen in the axial planes in the T1, T2 fat suppress and stir images, and we should see the neurovascular bundle involvement. So this is an example of aggressive lesion. This is a T1 weighted image, this is a T2 weighted image, this is a stir image, where you are able to see the extent of the marrow infiltration. It is also involving the physis. There is some soft tissue component associated with, which is nicely seen in the stir images as well. And then the T2, we are able to see there is periosteal reaction, which is seen in the posterior aspect. And also in the sagittal image, we are able to see the involvement of the epiphysis. Whenever we are assessing the lesion, we should always see the proximal and the distal joint, so that we need to see whether there is any skip lesion or not. This is an example where you are able to get this is a stir image where you are seeing multiple fluid levels. In the coronal image, you are able to see there is thinning of the middle cortex of the tumor. And the axial image, there is again there is thickening of the cortex, and on post contrast image you are able to see there is a heterogeneous enhancement. So this shows that this is a aggressive lesion with a fluid level. And this is a sagittal T1 weight image of the tumor, where you are able to see a complete lesion in the metadiaphysis, and this looks like to be a benign. Whereas this is another example where you are able to see that is a lesion with thinning of the cortex, and also there is some soft tissue involvement on the both sides of the cortex. So this is an example of a benign lesion, where this is a malignant lesion. Whenever we are assessing the response to treatment, what are the criteria for successful post-radiation and response to preoperative chemotherapy? Whenever there is a decrease of the tumor size and there is an increase in the T2 signal, that is because the fatty transformation of the bone marrow has happened. That says that it is a successful post-radiation case. In case of response to the preoperative chemotherapy, it is good when there is more than 90% tumor necrosis, and it is poor when it is less than 90% tumor necrosis. This is eyeballing, we can say that the percentage. When there is a decreasing extent of the marrow invasion, reduction of the tumor volume as compared to the previous preoperative or the pre-treatment scan, and there is decrease in the amount of associated edema. I would like to emphasize that the necrotic tumor does not restrict in diffusion as opposed to the viable tumor. So this will be assessed in the diffusion weighted imaging. This is an example of the pre-treatment. This is a post-treatment image. We are able to see a large soft tissue component of the lesion, which has significantly decreased in the post-treatment imaging, which says that there is a good response to the treatment. This is an example where we are able to see that there is aggressive lesion which is seen in the diaphysis of the femur of the unfused bone, which indicates as a child. That there is some cortical irregularity, and in this image, on the post-treatment, you are able to see that there is a decrease in the lesion size as well as the cortical irregularity. When we are studying the case for the detection of recurrence, the suspicion is high when the marrow replacement is there and the cortical disruption and osseous destruction has happened. In case of T2 signal, if it is low and generally does not represent recurrence, if it is high and surgery was the only treatment performed, then the likelihood of recurrence is high. If radiotherapy was also carried out, it is non-specific for the discrimination, recurrence, or radiation-induced inflammation in a T2 image. Postoperative fluid collection such as hematoma and seroma can be seen in contrast imaging on MRI, and this is seen as thin linear peripheral enhancement. Whereas in case of chronic post-therapeutic changes, low signal on T2 on dynamic contrast MRI, there will be early enhancement of the tumor in tumor tissue. This is an example of a recurrence where you are able to see that post-treatment there is a post-surgical implant over there. There is a large soft tissue lesion which is seen in the T1, T2 image as well as in the post-contrast image. So this is an example of a recurrence of the soft tissue sarcoma. This is an example where there is a this is a old scan and this is a new scan. In the old scan, you are able to see that there is soft tissue component over there. There is destruction of the bone. There is some fluid seen, and in the later imaging, if you see, there is no lesion in the soft tissue, but later on there is a lesion which is seen in the soft tissue. This is an indication of a recurrence. There are some mimickers of the malignant or benign lesions such as osteomyelitis, eosinophilic granuloma, infarcts, myositis ossificans, stress lesions, hematopoietic marrow, and aggressive osteoporosis. So here you are able to see that there is aggressive lesion which is seen in the femur with this large soft tissue necrosis over here. There is some soft tissue cystic area, and there is significant marrow alteration. And in the axial image, you are able to see that there is a periostal reaction which is seen. So, but this is an example of osteomyelitis. In case of eosinophilic granuloma, this is a case of a child where your MRI you are able to see that there is a widening of the marrow cavity, there is thinning of the cortex, and there is some soft tissue edema which is seen. So this may mimic a sarcoma. This is an example where in the radiograph of the elbow you are able to see calcification around the elbow joint. This is the T1 and the T2 weighted image where you are able to see isoto hyperintense on T1 and heterogeneous hyperintense on T2. And on post contrast, there is a mild enhancement. This is a case of myositis ossificans. In case of soft tissue sarcoma, what is the rule and why do we image need to do MRI? Is to assess the type and nature of the lesion, to characterize whether it's benign or malignant, to assess the disease burden and extent, how many lesions, how big the lesion, and how far do they extend. we need to assess any potential complications such like locoregional or associated complications and look for any associated syndromes. Also, we can assess the post-treatment follow-up. So, in ideal, scanning should be done with a skin marker at the site of the pathology. We should image both the limbs or full width of the torso. In case if it is in the torso lesion, standardized imaging sequences should be used, and intravenous contrast agent needs to be used. So, how do we need to exclude a malignant or benign lesion, sarcoma, from a benign lesion? So first you need to see whether it is a normal structure or not. Does it have a fluid level? Does it have a fat? Does it have predominant T2 low signal? If it is located within or adjacent to the joint, is it related to the tendon? It is predominantly vascular or it is whether nerve related. The features which can differentiate a benign from malignant are the mean diameter if more than 3.3 cm, which provides better sensitivity, and 6.6 cm better specificity. Irregular margins, facial invasion, presence of tumor necrosis, perilesional edema, bone involvement, neurovascular involvement. So these are all the features of the malignant lesions. And if there is a early enhancement, that is less than 6 seconds in case of dynamic imaging. There are some independent predictors of the tumor grade, such as necrotic component of the tumor, heterogeneous signal intensity greater than or equal to 50% of the T2 weighted image, and peritumoral enhancement. There has been a change in the classification of the soft tissue sarcomas in 2013, where they have included some new categories and they have excluded some previous ones, such as cyst is now a new categorization here. The pleomorphic malignant fibrocystocytoma and undifferentiated pleomorphic sarcoma is now coming to a new undifferentiated unclassified tumors. The mixed or round cell, now round cell has been excluded. Similarly, mixed type is excluded, and there are two new varieties which is coming as the giant cell fibroblastoma and dermatofibrosarcoma protuberans. This is an example of a T1 weighted image. There is a fat containing lesion. This example is being shown to emphasize on the pre-contrast T1 FS image. So in this case, this is a pre-contrast T1 and this is a post-contrast T1 FS. So you can see that there is no significant enhancement seen. So that's why we need a pre-contrast T1 FS image to compare it up with the post-contrast imaging. This is an example of a soft tissue sarcoma where there is in the leg, this is the tibia, this is the fibula, and there should be the interosseous membrane over here. So this there is intercompartmental extension of the lesion through the interosseous membrane. So this was a malignant, and there is all heterogeneous post-contrast enhancement. This is another example of a large fat-containing lesion. As this is a T1 weighted image, you are able to see that the subcutaneous fat signal and the lesion signal are the same. This is one side of the leg, and this is the other side of the leg. So by doing both legs, we are able to compare it that exactly at which location it is, and to differentiate that this is not a normal structure. This is a fat-containing lesion with some heterogeneous enhancement. This is a large lipoma with some malignant transformation. This is another aggressive lesion which is seen in the posterior aspect of the hip joint on the left side, which shows infiltration. If you compare on the right side, this is the sciatic nerve. Here the sciatic nerve is not seen, so this is complete encasement of the sciatic nerve by the lesion. So this is a follow-up case of a soft tissue sarcoma where there was a nodule was felt in the inguinal region at the site of the surgery. Ultrasound was done, which showed a large hypoechoic lesion with peripheral as well as internal vascularity. MRI was done, which really demonstrated the lesion, which shows significant enhancement, and this turned out to be a recurrence. There are some mimickers of the soft tissue sarcoma such as hematoma, tumoral calcinosis, accessory muscle herniation, and myositis ossificans. So this is an example post-operative where you are able to see a large fluid collection, and as on follow-up imaging, it is seen there is a reduction in the size of the fluid content. That is the case of a seroma. Similarly, as in case of this is the X-ray, where you are able to see the large area of calcification which is seen in the soft tissue. MRI also shows a large. This is a T2 weighted image where you are able to see large mass lesion, and this is a fat surface image. So this is turned out to be a tumoral calcinosis. This is another example where post-traumatic case where you are able to see a large soft tissue lesion with fluid level, and on post-contrast there is some heterogeneous enhancement. This is case of a hematoma. This is another example where there is some heterogeneous calcification which is seen, and there is some areas of enhancement as a hyperintensity, and there was no significant enhancement. So this was a case of a infective cellulitis. This is another case where there are multiple intraperitoneal soft tissue masses, and this came out to be intraperitoneal soft tissue sarcoma. This is another example post-operative where you are able to see a small fluid containing area and the superficial to the posterior compartment muscle, and post-contrast there is no enhancement. So this was a post-operative residual fluid collection. This is a large soft tissue lesion where you are able to see a cystic component. There is a large soft tissue mass which is invading all the muscle compartment, basically the posterior aspect of the leg. We are unable to see the neurovascular bundle. That's why there is a complete encasement of the neurovascular bundle in this case. This is the upper two images are the previous image which was done 2017, and lower to 2019. The follow-up imaging was done. If you see, the lesion shows a gradual increase in size, and then post-treatment is there is again the post-chemotherapy the size of the lesion decrease. So this indicates how we can follow up the lesion on treatment. This is an example of the post-operative left femur. Then there is one follow-up imaging. There was a cystic component which developed, and this shows peripheral enhancement. Aspiration. This came out to be a clear fluid post-operative collection. Now coming to the role of the dynamic contrast enhanced MRI. So before we go into the imaging, I would like to talk on three different types of graph, which is interpreted as a different type of vision based on the time intensity curve. This has been borrowed from the European Journal of Radiology article. This is the type 1 curve where there is early enhancement, and there is early washout as well. In case type 2 curve, there is gradual enhancement, and the enhancement remains there, whereas in type 3 curve there is a very gradual enhancement, and this is the same field. So this type 1 curve indicates there is a malignant lesion, whereas type 2 and type 3 are benign lesions. So this is a case where there was supposed to be a recurrence, and the area which is seen in the bone was T1 and T2 dark, and it shows post-contrast enhancement. On this regular sequence which we have performed, there was a confusion whether this bony lesion was a recurrence or it is a benign lesion. So then contrast enhanced MRI was done. This is again the same pre and post contrast imaging. On contrast image, if you see this is red, it showed a gradual enhancement pattern, so which is a type 2 type of kinetic curve. Uh, and if similarly, in the other soft tissue areas, it also shows that it was a gradual. So this came out to be a benign lesion. It was not a recurrence. So before concluding the teaching points, I would like to again re-emphasize that we need to know the history of the patient, what the treatment, we need to discuss it with the clinician. The radiograph is the primary screening modality. MRI is superior to other imaging modalities in detecting the bone marrow lesions. MRI is definitely very helpful in local staging and surgical planning, as I have showed you the examples. And MRI is also used in assessing the response to neoadjuvant therapy, restaging, and post